Thank you for allowing me to speak at this symposium. I'm going to be speaking about palliative care and GYN oncology. So I'm going to just discuss some objectives of this talk. Palliative care is actually a pretty underestimated and often underutilized resource that we as clinicians should be more familiar with. So this talk is actually going to delve into some basic definitions and tenets of palliative care. And look into the various models of palliative care. I'm also going to address symptom management and explore end-of-life care. This is a topic that I hope will actually provide you with some concrete information and possibly give you some new insights into this interesting topic. I've actually learned quite a bit from researching this topic myself, and some of the information that I've actually gathered has changed my practice as well. So what is palliative care? Palliative care is basically an interdisciplinary service that focuses on improving the quality of life of patients, their families, and their caregivers. It involves treating patients with issues related to life-threatening and serious illnesses, so it's actually not limited to only oncology patients. It can include patients with cardiac issues such as CHF or even neurologic issues such as Parkinson's disease or even dementia. Many of us have heard of hospice care, where we focus on end-of-life care for any issue related to a life-threatening or serious illness, but palliative care is not just limited to end-of-life care. Many patients will actually hear the term palliative care and they think hospice or end-of-life. But the interesting thing about palliative care is that it incorporates the care of the patient regardless of where the patient is in the natural history of their disease. Hospice care is somewhat of a different entity. It's actually an older concept compared to palliative care. However, some aspects of palliative care actually overlap with hospice care. Hospice care does provide medical care and support to patients with life-threatening or life-limiting illness, but it also focuses on the quality of life rather than prolonging life or actually finding a cure. It's generally utilized during the last weeks to months of life and centers around the concept of a comfortable death with dignity. The goal is not to prolong life, but to actually make the inevitable transition to death hopefully easier for both the patients and their families and friends. Patients who have a poor performance status, such as those who spend more than 50% of their time in bed or in a chair, who cannot dress or really care for themselves, are candidates for hospice care. Those that actually have an overall poor quality of life with depression, nausea, vomiting, pain from their illnesses would actually benefit from hospice care. And it's interesting to see that often family caregivers go through a similar type of stress as they follow the patient's illness. And so actually with hospice care, usually that's implemented as you start to notice more of a frequency of medical crises and as you start to see patients requiring multiple hospitalizations and ER visits. So there are many questions that patients will actually ask pertaining to hospice care, some of which are driven by fear of the unknown. And there are a number of misperceptions that I've actually come across with my own patients. Many have asked me these questions, and it's interesting to see what we as practitioners actually take for granted when assuming a patient and their family understands exactly what we're talking about when we discuss hospice care. And these are some of the questions that actually I've read through a previous article. And so I don't know if any of you have come across these questions, but some of my patients have actually asked me, is hospice a place? And generally, it's a model of care. It's actually not a physical location, and it can be provided in a patient's home, in a nursing home, or in the hospital. And then another question that people will ask is, what type of treatments can patients receive while being cared for by a hospice program? And the general consensus is that it's for maximizing comfort and the quality of life. And I think a really important point is that, and patients actually don't know this, is that they can come and go from hospice at any time, and especially if it's not meeting their needs or if a new treatment becomes available that's not able to be covered by hospice, which is actually something that I stress with my patients. So many people, when they hear hospice, they think it's a death sentence. But I always reiterate to them that if they feel that hospice is not meeting their needs or they're actually feeling better, they can actually come out of hospice. But the general criteria does include a prognosis of under 6 months, which is extremely important to stress. Another question is, do patients have to be actively dying to receive hospice services? Generally, what I tell my patients is this is more of an inability to care for themselves. So if they start showing a functional decline with a poor performance status and a poor quality of life, so they don't have to be in their last stages of life to actually be enrolled in hospice, but their prognosis has to be estimated to be less than 6 months. Another question is, do patients have to be DNR to receive hospice care? I think this is an interesting point because some patients are counseled that they have to be DNR or DNI to be enrolled in hospice. I try to explain all the care that goes along with resuscitating a patient and describe to them the actual actions that go into making an actual informed decision pertaining to code status. But in this country, we actually do not have to have them be DNR to be enrolled in hospice care. So then came the specialty of palliative care medicine. So it actually spawned from hospice care. And it's more of a concept that incorporated the philosophies of hospice care, such as holistic care and symptom management, with incorporation of communication. But palliative care includes a wider group of patients, including those that are actually not dying or who can't receive or choose not to receive hospice services. It incorporates all stages of disease, including the initial diagnosis, all the way to end-of-life care, and actually all the way into bereavement after death, which makes it extremely versatile since many people don't actually know about it. So in the field of G1 oncology specifically, most G1 oncologists are in the opinion that palliative care is useful, but underutilized. So there was actually a survey from the Society of GYN Oncologists, and they asked 145 people how they incorporated palliative care services and what barriers they found to incorporation of palliative care into their practice. So interestingly, 9 out of 10 actually offered palliative care services, and this was in this country. But 51% of them thought that the palliative care services were underused. 48% felt that they were appropriately used, and 1% actually thought it was overused. 30% said that palliative care should be incorporated at the first recurrence. 40% said that it should be incorporated when life expectancy is less than or equal to 6 months, which uses hospice criteria. And 3/4 said palliative care is reasonable at any stage of disease from diagnosis to end-of-life care. For G1 oncology, pain appears to be a major factor that drives palliative care consultations, but 63% reported that they would consult palliative care from other services and other symptoms such as intractable nausea, constipation, depression, anxiety, and fatigue. Interestingly, the majority said that the main barrier to consulting palliative care services was the patient's families' fear of abandonment, patients and families' fear of abandonment by their primary oncologist. And generally, there's a separate provider who can actually give palliative care services, which is discussed with the patient and the family. But it's important to note that these patients are, in fact, not being abandoned by their primary oncologist. So there's various models of palliative care. One is called the dichotomous model of healthcare, which incorporates palliative care closer to when death is expected to occur. And then there's an integrated model, and as you can see, hopefully, so the palliative care with the integrated model is incorporated as you're actually receiving disease-modifying therapy, and then it includes all the way, it goes all the way into hospice care and even into death and bereavement. So it's more of an integrated approach versus first giving disease-modifying therapy and then after patients start to deteriorate, introducing palliative care at that time. So here's the ideal model hashed out where palliative care is integrated into healthcare while the patient is undergoing life-prolonging treatment. And then, as we discussed, hospice is actually not instituted until after life-prolonging treatment ends, which differentiates palliative care from hospice care. Palliative care is recognized as a medical subspecialty, along with hospice, by the American Board of Medical Specialties. Additional countries such as Canada, Ireland, England, New Zealand, and other European nations have actually implemented palliative care into their healthcare services. There is an interesting article by Temmel from 2010, and they actually looked at patients with non-small cell lung cancer, and they actually found that these patients had a better quality of life and mood scores compared to those who received standard oncologic care alone. And interestingly, actually had a longer median survival that was statistically significant, so 11.6 versus 8.9 months, which I find very interesting. And then the American Board of Obstetrics and Gynecology has had people actually board certified in palliative care. The requirement at this point is to document 800 hours of end-of-life care and 100 hours of hospice experience, with the requirement for a written examination. So there are various tenets of palliative care that are important to address. One is management of symptoms, so pain, shortness of breath, nausea, constipation, delirium, depression, anxiety, or just to name a few. And different aspects of a patient's disease call for different types of management at various points in time, from the initial diagnosis to death. For instance, at the initial diagnosis, there may be symptoms actually associated with the initial shock of the diagnosis. And one of the most important tenets of palliative care is taking an interest in the patient's values and performing, as well as preferences, and actually, such as their religious preferences, to make a more cohesive treatment plan. Palliative care actually provides continued communication between caregivers and the patient, and provides psychosocial, spiritual, and practical support. And the key to palliative care is to coordinate care involved with everybody, including the patient, her family members, friends, and the other medical providers. So for the control of pain and other symptoms, pain can actually be very subjective. And so there are different scales that actually palliative care providers use to help alleviate this particular symptom. Other symptoms include psychological issues, but pain can actually be tied to depression and anxiety. This is an interesting point with the sense of control. One of the most important issues, I think, with dealing even with a new diagnosis is a feeling of a lack of control, particularly over the disease process. And it can lead to depression and anxiety and manifest as insomnia as an actual physical symptom. Palliative care is part of a progressive process, and with the team approach and integrating the services earlier in the disease process, the patient actually may develop a better sense of control. And part of this sense of lack of control stems from a lack of understanding of the actual nature of the illness. So implementing palliative care earlier actually will hopefully allow them to understand the natural course of the disease, thereby improving their overall outlook. Palliative care also helps with relief of burden on family members and strengthens the relationships between family members as well as the patients. There's a lot of issues that cause tension and shifts in actual family dynamics. And palliative care teams incorporate family members with the patient so that they can even often address their feeling of lack of control. So having a cancer diagnosis actually doesn't just involve the patient, but their family and friends are just as involved, particularly emotionally. So the crux of one of the goals of palliative care is to actually understand the nature of the illness itself. So as you can see, palliative care involves multiple aspects that need to be addressed to optimize patient care. And these are not only physical issues that get addressed, but psychological, social, spiritual, cultural, ethical, financial, and even legal issues. Issues that are not actually properly resolved can contribute to added stress, thereby affecting the patient's outlook on life and their perception of death and what they're potentially leaving behind. And the goal is to treat the whole person and whatever makes that person who they are beyond their cancer diagnosis. So expectations in the future are another part of the goals of palliative care. One of the most important questions to ask the patient is what they're expecting in the future, such as their understanding of their disease process and how their treatment will affect their disease, such as if they're expecting a cure, or do they think that the treatments that they're receiving are for palliation only? Are they expecting that a certain drug will eradicate their disease, or do they feel that they'll succumb to their disease sooner rather than later? And some patients may hear from their oncologist that their disease is not curable and may respond with anger or sadness because their expectations for living for a certain amount of time have been crushed. Additionally, when is it best to continue on with the treatment is another issue. And so palliative care actually addresses the pros and cons of the available treatments. So one question would be, is the chemotherapy that the patient receiving going to make a difference in their disease, given the side effects and based on their performance status, and also keeping in mind their overall quality of life. The other goal with palliative care, excuse me, is also that it addresses to help make people available for decision-making capacity, their own medical decisions for various reasons, which is also an added stress. Financial affairs is also a very important issue because it can contribute to quite a bit of stress for the patient and their family members. And these issues need to often be discussed since there can be changes in family dynamics, particularly when dealing with financial issues. So examples would include funeral costs and having enough money for the next of kin. And these are issues that are often not addressed by the patient's primary oncologist. Palliative care can be delivered in a hospital or ambulatory setting, or nursing home, or actually at home, which I'll get to in a separate slide. It is reimbursed by most insurance companies, and studies have shown that early palliative care implementation has resulted in lower hospital costs, and the savings are even higher for patients with cancer and or four or more comorbidities. Palliative care is very diverse and versatile, as it can be delivered in a hospital setting, nursing home, or home itself, but it doesn't mean that the patient's actually laying in a hospital bed at home. But it does mean that many subjective symptoms can be treated by a palliative care provider while providing emotional support as well. And I think we actually have a really great resource here when we have our patients see our palliative care providers in an ambulatory setting, which is something I actually never encountered when I was in fellowship at Iowa. My patients love the idea of actually having that continued support that they're getting treatment, and then they tell me that it's a useful outlet, and many go to ambulatory appointments even when they're actually feeling well. But the sentiment is actually not necessarily recognized across the country. There is an analysis that I came across that shows that physicians from higher spending areas actually reported less comfort with discussing end-of-life issues, and actually had more negative attitudes associated with hospice care. They don't feel that patients would actually benefit from this unique service because they're not actually familiar with how it actually can positively affect a patient as an integrated model of healthcare. And many patients may feel isolated and shocked, particularly if their physician is not as well versed in delivering bad news. And this contributes to higher anxiety on behalf of the patient and their family members. These physicians need to understand that treating a cancer patient actually doesn't just involve medically treating the patient's cancer, but also treating the whole person, including their emotional well-being. And so therefore we need to have a more integrated approach to build a better health care or medical care to decrease variations between caregivers in delivering this health care. So the NCCN has provided a list of guidelines which include recommendations pertaining to palliative care specifically. NCCN guidelines are actually what we look to as oncologists for different types of cancers in terms of recommendations for treatment. And so I looked at the NCCN guidelines specifically for palliative care, and they include patients with uncontrolled symptoms, such as pain and GI symptoms. It also incorporates hospice care into the model and includes those patients who have less than or equal to 6 months of life expectancy. Those that show distress related to their diagnosis and treatment should be included, and those that have concerns about their course of disease and their treatment options. Again, the underlying issue is actually trying to have the patient gain a sense of control over their diagnosis and treatment and symptoms, just making it more of an integrated approach to healthcare. Family members are, again, part of the patient's whole journey and actually should be included in the integrated approach. Palliative care does focus a lot on pain, but also addresses the psychology of mortality. Patients have to often be counseled that life is a normal process of evolving from good health to ultimately inevitable death. Changes are normal throughout life, and the way we eventually cope with death will actually solidify our perception of death. Palliative care is not involved in neither postponing nor hastening death, but death is a natural process which is generally discussed with the patient and their family. Many patients are fearful of death and what occurs and what to expect at the time of death, and palliative care providers address these issues. I've actually had patients ask me if their death would be painful, and I try my best to inform them of the physical symptoms that they actually may experience, but I feel it's our duty to actually inform them of what to expect if they wish to hear about it. Palliative care service incorporates these questions into the overall treatment, and therefore this is more of a team approach with nurses, mid-level providers, and physicians in addressing the patient's concerns. And it should be considered early in the course of illness so that all of these questions can be addressed head-on as long as the patient is comfortable with hearing about them. It actually may decrease their anxiety and their depressive symptoms as they go through the course of their illness. There's some other definitions of palliative care that I've come across, one from the Centers for Medicare and Medicaid Services, so CMS, and another from the Center to Advance Palliative Care. And the main thing that both of these look at is this extra layer of support that palliative care provides, and that, as you can see from the Center to Advance Palliative Care, the last part of the sentence that says can be provided along with curative treatment. So it's a little bit different from hospice in the sense, again, as an integrated model, it can be incorporated even towards the beginning of the diagnosis. The World Health Organization also has its interpretation, and basically it's more of the early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it's not just treating the cancer itself, but again, it's more of an integrated model of treating multiple aspects of the patient. So in my fellowship, we actually didn't have a formal training program in palliative care. So I would listen to my attending deliver bad news to patients and actually just watch the body language and pay attention to the speed of their talking and their voice. And when I was a senior fellow, then we would actually have those difficult talks to the patient ourselves and would get feedback from the staff. And so I've researched the topic of the education of providers in palliative care. And to be a GYN oncologist, you have to go through a 4-year OB/GYN residency and then do a 3 to 4 year GYN oncology fellowship. And so an article that I came across that looked at trainees in fellowship programs and their experience with actually delivering bad news to patients, most of those fellows actually didn't think that they were as comfortable with actually delivering that type of news. And so this actually increased the stress and anxiety of the patient and the family because of the way that the news was being delivered. So these conversations actually can be very uncomfortable because there's so much that's unknown. And in this article, they actually came up with a protocol called a SPIKES protocol, which I'll address in the next slide. Sometimes actually patients don't understand the news or the family interprets it in a different way just because of the lack of the ability of the physician or medical provider to address that bad news accurately and appropriately. Sorry. So this is the SPIKES protocol. This is from MD Anderson, and they've used it actually at Sloan Kettering as well. So S for SPIKES means setting up the interview. And so a thing that's actually very important, which I think needs to be stressed, is to actually sit down with the patient A lot of times when you speak to a patient while you're standing up, it's very intimidating, and so you want to be on their same level. Arrange for privacy and involve significant others. So I would generally ask patients who else they would like to be involved in the conversation. And then make sure that you manage time constraints and interruptions. So I usually try to tell my office to take pages, or I will try to avoid answering pages unless it's an emergency while I'm trying to talk to a patient. The other step is to assess a patient's perception of actually what's going on. So I actually use this quite a bit. What's your understanding of your medical situation before actually delving into the diagnosis? Usually I'll ask, how much do you know and how much do you understand regarding your situation? Obtaining the patient's invitation. So how would you like for me to give the information about your test results? Sometimes I'll ask patients, do you want me to go over your scan with you? Do you want me to draw your pictures? I start by drawing pictures. And then slowly determine how much they're actually understanding before I start to talk about whether they'd want to actually see the CT scan themselves. Some patients don't want to actually see any images, and they just want to see it on paper, and that's as much as that they want to absorb at that time in small chunks of time. Giving knowledge and information to the patient. Generally, some people will say, I'm afraid I have bad news. I usually don't say that myself. Usually I just ask, what's your understanding of your medical situation, and then just start to slowly summarize what's been going on with the patient. But generally we try to avoid excessive bluntness. And what's very important is to actually give information in small chunks and then make sure that the patient is understanding what you're saying. So a lot of times with my patients, I'll actually say, does this make sense? Or do you need me to repeat that? Or can I go on to the next part as I speak with them? And then step 5 for the E part is empathy. So generally you'd like to pause and observe the patient, look at their body language, look at their face, and try to identify their emotion. And then let the patient know that you're actually connected with the emotion, even if you haven't experienced what they're going through yourself. And then strategy and summary. So generally for my patients, what I'll do is I'll try to summarize everything again, as long as they don't seem too overwhelmed, and then actually ask them what they're fearful of. So some of this I've actually integrated into my own practice, and then I actually found this protocol that other people are using more in a training situation or training environment in other institutions for fellowship programs. So in summary, the benefits of palliative care would basically be to improve the patient's quality of their care at end of life and actually before they go through end of life care. It does improve their coping skills. It helps avoid hospitalization and it lowers their costs. It actually avoids unnecessary interventions. So some patients, if they're involved in palliative care or even hospice care, you can avoid repeated radiographic imaging, ER visits, ICU stays, which actually improves their quality of life. And then you can slowly transition them to hospice care. Overall, the previous studies have shown an improved patient and family satisfaction. And it actually appears to reduce PTSD among family members, which I found in other studies as well. Like I said before, models of palliative care include consult services, so they actually, in our hospital, they can be consulted in the hospital, and then followed in an ambulatory setting in a community-based palliative care service. There's palliative care units in hospitals as well. And then there's integrated palliative care models, such as in an ICU setting. And then nursing home palliative care, which depends on what the needs are for each patient in the nursing facility. There are some barriers for referral to palliative care. The main thing is this low awareness that palliative care actually exists. Again, most people do think that palliative care and hospice care are the same thing. And so whenever people think that, they actually say, well, this is mostly end-of-life care, so I'm not going to consult a palliative care specialist because that means that this is the end for the patient. Some providers think that palliative care could interfere with treatment, but it's actually a really good adjunct to patients while they're receiving treatment. And there are a shortage of providers that are actually well-versed in palliative care. The other thing that's actually a barrier is if you speak with a patient and you say palliative care, a lot of times they again think hospice care, so it's not just the providers but also the patient themselves. And so some providers actually use supportive care instead of palliative care in their language when they speak to patients. Other barriers for referral to palliative care include difficulty switching to a non-treatment regime, discomfort with actually having the conversation about death with the patient and the family. And some patients and family members have this continued search for cure, and so they get very fearful of being involved in palliative care because, again, they think that it's associated with hospice care and no more treatment. But that's actually the opposite. So again, palliative care can be integrated even while patients are receiving treatment. There are some challenges to palliative care, and this is in cancer patients as well when speaking with some palliative care providers. So older age greater than 65, they tend to have more comorbidities such as cardiac and renal issues. Malnutrition and low serum albumin can actually affect drug metabolism and their overall functional status. Decreased renal function that actually can affect their metabolism of drugs and even cognition. Impaired cognition, which interferes with making their decision-making capacity. A lower seizure threshold, such as those who have metastatic brain involvement and with the use of opioids. Long-term opioid therapy, which actually makes it harder to provide other pain medications because these patients tend to have more of a resistance to the other pain medications. And then multiple drug therapy, where these other drugs can interfere with other agents that they're trying to provide. Frequent autonomic nervous system impairments, so some patients will have other symptoms that aren't going to be treated easily with, like, so let's say an opioid, so excessive sweating, dry mouth, dry eyes, or flushing. So I'm going to go into specific symptoms and some of the tools that palliative care providers have provided. So one major issue that we have in our G1 oncology population is dyspnea, which can be related to pleural effusions or even from massive ascites that causes distension to the point where people have shortness of breath just from that added pressure. And so this is a very subjective symptom. It's a very scary symptom. It can be associated with anxiety and depression. So some providers have actually provided cognitive behavioral therapy, more as a relaxation technique. Some people have used a cooling fan. Others have offered opioids, such as morphine. And then dyspnea that's related to pleural effusions, a thoracentesis, and ultimately pleurodesis at times. But keeping in mind that pleurodesis can be associated with pain and atelectasis as well as pneumonitis. And some people have used indwelling tunneled pleural catheters as well. But again, dyspnea is a very subjective symptom. Cachexia and anorexia is probably one of the harder things to watch in a patient as they essentially lose weight and just not feel like eating. And this can actually incorporate family member distress as well as they watch their the patient essentially get smaller and smaller. So cachexia is more of a hypercatabolic state. It's associated with the loss of skeletal muscle secondary to an inflammatory response. So in our patient, it's related to the cancer. And anorexia is a loss of appetite with weight loss. There's a decreased frequency of eating, less variety of foods. Things just don't taste as good. And patients have more of a higher liquid intake. And actually, extra calories do not seem to reverse the underlying process. But again, in my patient population, I start to see the family members get more and more stressed out from watching their family not eat. So this is addressed by the palliative care service as well. For GI symptoms, things that can be done would be to reduce red meat for some patients. For others, to consider more dairy. So sometimes with protein shakes, they'll implement the use of ice cream. Some of them will actually marinate the meat to disguise the taste. I thought this was interesting to actually serve foods at room temperature instead of hot, and to try tart foods. And that can sometimes help with the nausea. We've all used glucocorticoids for intractable nausea and hopefully to sometimes improve their appetite as well as their energy. This is more of a short-term treatment strategy. So you can try glucocorticoids at 4 milligrams PO daily. Megace has been used in some cancer patients. I generally haven't used it in my cancer patients for improving appetite, but there is an increased risk for venous thromboembolic event, adrenal insufficiency, and edema. It can actually also be associated with increased risks of depression. And then when it comes to cases of dehydration and patients would like to be hydrated, it's actually not shown to prolong life and actually may not be covered by insurance companies. One of the harder conversations to have is whether a patient should have artificial nutrition to prolong their life or to improve their nutritional status. And so the question is whether they should be placed on TPN. It's rarely done when patients are more in the end-of-life arena, but in cases of high-grade obstruction or malabsorption, it can be considered, but it actually just should be frequently reassessed. Nausea and vomiting is also associated with opioid use and impaired gut motility. Generally in our patient population, it's from peritoneal carcinomatosis, which can actually affect the peristalsis of the gut. Uremia, which is more of a progressive weakness and easy fatigability, loss of appetite, and can be associated with metabolic acidosis, so more signs of kidney failure. Electrolyte imbalance, hypercalcemia, and some patients with nausea and vomiting that's intractable might have cerebral metastases, so that always should be considered as well. Malignant ascites is also a challenging issue. It goes hand in hand sometimes with pleural effusions where they cause dyspnea, but malignant ascites is generally associated with an obstruction of lymphatic drainage, hepatic venous congestion, and the vascular permeability actually is changed. So some patients benefit from paracenteses, but if you feel the patient is getting repeat paracenteses, that can actually increase the risk of an infection. So some patients are actually considered for a Pleurex strain. There are agents that people are looking at to target a malignant ascites, such as VEGF and HIPEC, but these are actually under investigation. If patients are more towards their end stage of life, these are actually toxic agents, so generally we don't recommend them. Malignant bowel obstructions are actually difficult to deal with as well. So 35% of patients with relapsed ovarian cancer will have a malignant bowel obstruction. Generally, we conservatively manage them with an NPO status, IV fluids, and nasogastric decompression, and then medical management of nausea. The hardest thing I would say as a physician is to consider, should we do surgery or just continue conservative management? This actually makes the family distressed as well, because many times patients will come in expecting a surgery. And so as a physician, I usually look at their life expectancy and what I feel they'll benefit from the site of obstruction. So generally people who have a malignant bowel obstruction from a metastatic ovarian cancer will have multiple sites of obstruction. And so I try to tell the family that if I took them to the operating room and try to resect a portion of bowel and put it back together, I'd basically be putting tumor back to tumor, and that would just break down. And then I also look at the chance of response to further chemotherapy, so that they would be a chemotherapy candidate in the future. But a review of 700 surgeries for malignant bowel obstruction found that the major morbidity was 32%, and the median survival was only 17 weeks when you actually did surgery. So again, a very challenging topic to discuss with the patient and their family. Hypercalcemia, there's different definitions of hypercalcemia, but generally a total serum calcium of 10.2 adjusted by their albumin. So you usually have to adjust it for albumin because most of our patients that come in will have a lower albumin just from malnutrition. It occurs in up to 30% of people with malignant disease. It can be associated with very nonspecific symptoms and generalized symptoms such as nausea, vomiting, anorexia, constipation, polyuria, irritability, depression, muscle weakness, delirium, and coma. And people who present with hypercalcemia, their survival is thought to be less than 6 months. Generally, you treat with intravascular volume expansion with a 1 liter bolus of normal saline at a higher rate of up to 150 cc's an hour. And then we have used bisphosphonates with calcitonin in severe hypercalcemia. Psychiatric symptoms are also addressed by the palliative care service. Generally, the major one would be major depression. There's many things that go into psychiatric symptoms, such as a feeling of hopelessness, helplessness, excessive guilt, loss of interest, and some people even have thoughts of suicide. Sleep disorders, so a lot of people actually complain of insomnia, poor concentration, which actually affects their overall ability to want to eat something as well, which can contribute to anorexia, and then psychomotor retardation. Pain, again, can go hand in hand with depression and anxiety, and so psychotherapy is often implemented, but some patients will actually have demoralization, which is more of an existential distress associated with their symptoms. Delirium can be associated with opioid-induced neurotoxicity. It can also be associated with brain tumor and metastases. Sometimes various cancer treatments can exacerbate delirium as well. Some people have used psychotropic drugs such as TCAs and benzodiazepines, but other things to keep in your mind for delirium would be metabolic factors like electrolyte disturbances and dehydration, or failure of a vital organ or system. Some perineoplastic syndromes are associated with delirium, and other things that should be considered would be infections and sepsis. The treatment of delirium, it depends on the underlying cause. So, but one of the major things is to actually try to keep the patient oriented, so to provide familiar materials and to minimize the use of restraints, which actually, if you use restraints, can contribute to significant anxiety. Interestingly, to use glasses and hearing aids for better communication, and then having people that they're familiar with to reorient them, such as a companion. Haldol seems to be better in cases of delirium than Ativan, and so there's standard dosages that can be given for Haldol, but older patients actually may require lower dosages. And then consider changing the opioid if the patient continues to be delirious, or to correct the metabolic derangements, address infection, and continue to hydrate the patient. You also can consider midazolam for a short-term measure in the last hours to days of life, especially if the delirium is not responding. Brain metastases are somewhat of a difficult issue as well. Can be associated with headache, intractable nausea and vomiting, seizures, hemiparesis, gait disturbance, and visual changes. So generally for cerebral edema that's associated with brain metastases, we do initiate steroids at times. These are just standard dosages that we've given. Radiation is also a consideration. There isn't a surefire way of how much radiation to give or when to give it, but depends on the number of lesions and their control of the disease. So if they have 1 to 3 lesions with poor control of disease, then it's best supportive care with whole brain radiation therapy. There could be a consideration for consultation with neurosurgery to see if the disease is surgically resectable, if you feel that additional therapy can be offered and there's only 1 to 3 lesions. There is the possibility of whole brain radiation or stereotactic radiosurgery if patients have a poor prognosis or performance status and there's 4 or more lesions. For hemorrhage, this is also a difficult thing to see, especially in a hospital setting. So ensure the presence of a healthcare professional if it's possible. Provide psychological support to the patient and the family. Something that actually I haven't seen too much in my previous training was to use dark towels to try to hide the blood and to use suction. Some patients for us, for our G1 oncology patients, require vaginal packing, and oftentimes we do have to do radiation therapy just for palliation of the bleeding over 2 to 3 days. This is just a slide just to give family members specific things that they would expect from the patient themselves. So progressive unresponsiveness, purposeless movements, their facial expressions. Some patients will have noisy breathing. And then ask about previous deaths in the family, where, when, and how. So I've heard multiple family members say that they had a terrible event with a previous family member, and that's what actually makes them develop PTSD. And then what to do after death. In terms of how, if there's an autopsy, that would be necessary, or what type of funeral arrangements that they would like to have. The last days to hours of life, there's a decreased level of consciousness, difficulty with swallowing liquids, periods of apnea, chain strokes breathing, which is actually difficult to watch at times because patients will have more of a deeper breathing and then they go through periods of apnea. There's a death rattle, which is generally associated with respiratory and oropharyngeal secretions. So a lot of times patients are repositioned and there's a consideration for glycopyrrolate or scopolamine. Many of them develop peripheral cyanosis or pulselessness of the radial artery, respiration with mandibular movement, and a decreased urine output. And then the last hours of death shouldn't generally be entirely focused on comfort care, discontinue non-supportive drug agents, stop imaging and lab testing. So generally if we have patients dying in the hospital and palliative care is following them, they just completely stop the lab testing, which actually can make family members a little bit distressed at times if they don't understand why. Deactivate a defibrillator so that it doesn't go off. Change oral medications to subcutaneous or IV. And one study I come across that 1/3 of cancer patients actually die in the hospital. So in conclusion, palliative care should actually be implemented early in the disease process, and it focuses on the quality of life of the patient while she's undergoing treatment more as an integrated approach. It's important to educate patients and family members about the difference between palliative care and hospice, and provide continued support from diagnosis through death and bereavement. One quote that I found that I thought was really interesting is that palliative care is both an art and science of care. Thank you.